admit ചെയ്തോ? Good morning, everybody. I am Dr. Rajiv Sukumaran, the Scientific Committee Chairman of KSOS. Let me welcome you all to this online CME series being conducted by the Kerala Society of Ophthalmic Surgeons under the leadership of Dr. Meena Chakravarti, President of KSOS. Let me welcome the optometrists also. Just a minute, please. Let me know. But it's a echo, madam. Little echo is coming. Let me. Okay. These CME series were started ever since the lockdown was implemented, and it was continuing. To place on record, the CME done last week with Dr. Mahi, talking on OCT has hit the YouTube like a storm with over 1,000 viewers and more than 25,000 minutes of viewing. And so with that, today we have two eminent speakers, Dr. Anil and Dr. Vinay, both stalwarts in corneal disease, will be talking on corneal topography. They will be formally introduced by Dr. Mini Jayachandran after a few words by our President, Dr. Meena Chakravarti. Madam, over to you.
Good morning, everyone. Nice to be here today. I thank Raji for taking this tremendous effort to organize the weekly CME. It is a great boon to the postgraduate students, the feedback that I get. My daughter, who is actually not a member of our society, also attends these meetings. And it is well received by most of the postgraduate students. Sometimes I feel that I should have gone back to my postgraduate days where so much material is available at your fingertips. I welcome both the speakers, both eminent people in their own fields, and I am sure it's going to be a very, very interesting meeting. Over to you, Rajiv.
Thank you, madam. Dr. Mini, madam, can you please introduce the speakers after unmuting? Vinod, can you please unmute her?
Myself.
Yes, you can introduce now.
Good morning, all. As Rajiv sir said, we have two speakers today. First speaker is Dr. Anil Radhakrishnan. He is presently consultant in cornea and refractive surgery at Amrita Institute of Medical Sciences, Kochi, and is also in charge of Amrita Eye Bank. He did his MBBS from Calicut Medical College and MS from RIO Bangalore, and fellowship in comprehensive ophthalmology with specialty training in cornea from LV Prasad Eye Institute, Hyderabad. He has been practicing cornea and refractive surgery ever since. His area of interests are corneal infections and anterior segment surgery, imaging. Second speaker is Dr. Vinay Pillai. He is senior consultant and head cornea and refractive surgery, Irregular Eye Institute, Kochi. He did his MBBS from Government Medical College, Trivandrum, PG from Minto Hospital, Bangalore. He worked as associate consultant in cornea services in Shankara Nethralaya, Chennai, and LV Prasad Eye Institute, Hyderabad. His area of special interest is ocular surface disorders, keratoprosthesis, and high-risk corneal transplants. Thank you.
Thank you, madam. Dr. Anil, can you share your presentation?
Yeah. I hope it's coming, sir.
Yes.
Okay, fine. So thanks for the kind words, Dr. Mini. I think I'll just take 1 minute to just tell about the KSOS, what they're doing. I think world has both takers and givers. I think our society, our Kerala Ophthalmic Society is very endowed that we have in their leadership a lot of givers. So unless you have a lot of givers who are able to give you time, give people time on their own, without anything getting, without expecting anything in return, the takers cannot take anything. So we are very, and I think I would urge our fellow presenters also to give their presentations so that it can be shared in the common platforms. I heard a few comments about some people telling they were very possessive about their presentation. I think information has to be shared. I think it's the culture of India. It's not like US. You don't charge a few $1,000s for a small 1 hour talk. It's not done. In our culture, it's not there. So I think we should freely exchange our presentations and so that most people can benefit. I'll be talking about corneal topography. I think I'll spend about 20 minutes, basically about the basic principles and how to interpret the maps. And Vinay would be coming into with more detail regarding the tomography and the newer technique, which is the in thing now, which is the Pentacam imaging. So if you look at this image here, Rajiv sir, I'm seeing some lines on the screen. Is it there or?
That's, you're moving your mouse.
Okay,
Don't touch them.
Okay.
If you want to disable that, go to the left side. Animation will be there. You disable that.
Okay, fine. Okay. So this picture shows like a row of buildings and a plain mirror-like water surface in front. And on the first look, it appears that everything is reflected just like a plain mirror. But if you look at these small areas, like on top of the buildings and all, there are minor imperfections. These imperfections come due to ripples on the surface of the water body. So these are not because of the imperfections on the building per se, but it's because of the thing on the surface. That is exactly the principle of topography. So the in this cornea acts as a mirror. In fact, cornea is a convex mirror, unlike in this scenario. There is another advantage with that. In topography, if you know the size of the image and size of the object, you can compute, you can calculate the curvature or the property, surface property of the surface that we are talking about. And then another thing about cornea is that it's a convex mirror. So the image that you see would be magnified. So this is the corneal image. I think if you see the image, your image on the cornea, it will be much larger. So this is the principle, what I told, that cornea acts as a convex mirror. There is a principle of keratometry, keratoscopy, video keratography, and everything. The keratometry has been there in the literature and has been practiced for quite some time, more than about 100 years or so. But the disadvantage is that it measures only a small area, and it makes an assumption that cornea is a symmetrical spherocylinder. For that reason, it's not very accurate for the very flat or very steep corneas. And once you go beyond the central area, it is totally inaccurate. So these are the components of the topography system. One is the thing which captures which throws this cylindrical rings onto the cornea. There are 2 or 3 video cameras which capture the images, the reflections on the cornea, which is sent to the computer, which is processed. So along one ring, you have approximately, in the older systems, you have about 25 illuminated wires, and on each wire, you have about 256 points. So the location of this point on the cornea in relation to the central fixation point is calculated by a computer, and a printout is given based on certain algorithms. So this is the printout that you see. In the printout, you can see there are multiple things. One is if you look at the lower panel, you can see that there is one called KS, which is the steep value. Second is the flat value. Then you have the cylindrical value. Then you have something called SRI and SAI and potential visual acuity, which I'll be coming into later. So I think of all topographies basically look at the axial map, which assumes that if you go beyond the central 3 millimeters, it is inaccurate. So I think for all practical purposes, we need to look only at the axial map. Refractive, I just want to show this refractive power map so that you understand what is an axial map or inherent problem with the axial map. So this is a calibration ball. If you take an image of this in an axial map, the whole thing appears green in color. While if you take if you see the image on the other side, if you take the refractive power map, you can see that the central 3 millimeters green. Beyond that, there is a change in color. That is because it has taken into consideration the oblique incidence of the rays of light. There are multiple maps. I don't think I'll go into the details. I'll just say that the first one is a patient who has undergone a LASIK procedure, and you can see that the central cornea is flat. In that axial map, it looks like it's blue in color. In refractive power map, central part is exactly the same, but beyond that, you can see some shades of yellow and orange and even red. But if you see the instantaneous curvature map is used it is basically used in research purposes. It's not useful for routine practice. So it's very important that you align the patient's cornea to the topographer very well. So you should get a proper keratograph. Then only you can get a good reading. So there should be minimum lid shadow. There should not be any dry spots or pooling of tears. And we should make sure that these are continuous rings. So just see the images here. On the left-hand side, you have the image which is taken properly. And in the right side, you have rings which are broken up. And when you have broken up rings, this is a problem with Placido topography systems. If you have the surface is bad, the image quality would suffer so much. So you can see that it is a very irregular pattern. The same thing here. This is a patient who has done topography multiple times. You can see that there is an area of inferior steepening. This steepening is because of the tear meniscus or the tear pooling that has occurred in the lower part of the eye. This is another picture I've taken. I have told the patient to actually deliberately look up. If you look up and you can see images like this. So this basically tells you that if you don't align properly your eye, and if you're looking not straight, the images can be totally erroneous. So in a topography map, we generally look at the absolute scale, like between say this 35.5 to 50.5. The change in color occurs with a change in the refractive power of about 1.5 diopters. Beyond that, every 5 diopters only there will be a change. There are two other parameters. I think these two are important. The surface asymmetry index is something very important. It was very important about 10 years ago, but now because of the newer advanced imaging systems, we give less importance to that. So basically, you look at corresponding points. For example, if you see a point at 90 degree, you have to see a point exactly opposite to that. It will not be, it will be about 270 degrees. If it is 10 degree on that side, it will be about 380 degrees, like that. The corresponding points are taken. So in this, we basically sum up the differences in corneal power between the corresponding points in these 128 separate meridians, and these tell you about a surface asymmetry of the eye in total. While surface regularity index is the summation of local power fluctuation along all the meridians, and that correlates with the spectacle corrected visual acuity. So the SRI normal value is less than 2, near about 1, but more than 2 is abnormal. While SAI up to 0.5 can be considered normal. Beyond 0.5, it is considered abnormal. So these are the normal topography patterns. I think the intention of presentation was to basically how to interpret a topography map. So in this map, I think you should look at, first thing you should look at the K values, K1 and K2. So if it is high, if it is beyond say 47.5, you should view it with suspicion. Then you should look at the surface asymmetry and the surface regularity index. If that is also high, like normally if it is out of the normal range, it will be highlighted in yellow or orange. If it is way abnormal, it will be shown in red. So in this, you can see that SAI and SRI are well within normal limits. It's both less than 0.5. So it should be considered normal, even though the shape of the map is not exactly perfectly normal. So this is a round topographic pattern in which you see that the central cornea is slightly more steeper than the periphery. This is a normal astigmat. This is actually my topograph. You can see, first you should look at the K values. You see the K values, it is 47.7 and 44.3. It's slightly on the higher side in the right eye. But if you look at the other parameters, whether it's symmetrical or not, if you look at a point you can see the ring there. I don't have a pointer, that's why I cannot show you. With this on the ring, exactly the corresponding points you should see. If you see the point there, it is corresponding to about 47, and the same point near down, it will be coming to around 46.5. So the difference is hardly about 0.5. So it should be considered as normal. If it is more than 1.2, it should raise suspicion. If it is more than 1.7, it is very likely that it's abnormal. So this is another patient in whom you have this thing. First, you should look at the K1 and K2. Obviously, it is 43.57. It's perfectly normal. The amount of astigmatism is only 0.47, again normal. Other parameters, like in this particular map, you don't have SAI and SRI, but that also you should see. And you should look at the corresponding points. And if it is almost in the same color, so it should be considered as normal. Well, look at this picture. You see a small area in which you have a red spot. And the red spot, the color corresponds to something like 48.5 to 49.5. So this is clearly abnormal. But how can a red spot come only in one small area? It is not possible in the normal cornea. So then you go back to your keratograph, see whether the rings are proper. We saw that there is a dry spot there. So we do a repeat topography and it is seen to be perfectly within normal limits. There are certain other things which come along with the topography, like you have inbuilt software which can tell you about whether the cornea is normal or abnormal. So this is a very popular software which is used, Scheimflug software, in which they look at about 10 parameters, and based on that the computer tells you whether it is keratoconus or keratoconus suspect or well normal. In certain other systems you have something similar, but this is in size system you have this thing called in which if you have a keratoconus like pattern, it will show as KCN pattern, or else it is a myopic LVC or a hyperopic LVC, like that it will show. So basically we should, software is there to assist you, but I think you should always look at the raw data and then you should come to an impression yourself. There are certain other things that you can do in the topography also. This is a patient who has got a keratoconus, and we have done a cross-linking, and we have seen that there is some decrease in the keratometry. You can see that the red color has really reduced. There are some things available like power difference map. This is before and after LASIK, and you can see the amount of deviation in the keratometry that you have done because of the LASIK. There are other applications like elevation map also, but I think a word of caution here. For a Placido system, elevation map is only secondarily derived. It's not true elevation map. So you should not pay very much stress on this. But elevation maps are also helpful, but generally not as helpful as in other systems. When you have tomography systems like OpScan or Pentacam, it is much more helpful to look at the elevation maps. So how do you make a diagnosis of keratoconus? I think I'll go with a few very common examples, that's all. So keratoconus is something that we have to rule out with topography. So in keratoconus, you'll have a prolate cornea. Normally, even otherwise, you have a prolate cornea, which tells you that the central part of the cornea is more curved compared to the periphery. Then there are certain patterns in which normally you have a symmetry in the bow tie pattern that is seen in astigmatism. So I think I'll show you demonstrative pictures and with which we can explain. So this is an example of a patient who has got keratoconus. You can see that in the left side, you can see that it's very red in color. First thing, you look at the K values. You see that it is 43 in one meridian. In the other meridian, it's seen to be 64. So anything more than 47 is definitely abnormal. If you have values more than 50, it has to be keratoconus unless proved otherwise. And you see the amount of the symmetry between the two areas. Like one part of the bow is much more shorter than the other lower half. The upper half is much more shorter than the lower half. So this is asymmetric bow tie. And also, if you look at the values here, if you look at the, I think if you have a pointer, you can keep it over this and see in the topography machine. And you can see the value which is corresponding in the picture there. This value on the lower part will correspond to something like 51 or 51.5, which is way abnormal. Compare with a astigmat who has a symmetric bow tie. The two bows of the tie are somewhat symmetrical. I think it's the same picture I showed before. In the left eye, you can see there is a small asymmetry in the bow tie, but I think if you look at the values, it is almost okay. The difference is about 0.6 or 0.7. Second parameter is that it is both in one line. That is not seen in keratoconus. In keratoconus, it is most of the time it would be an asymmetric bow tie because two bows of the tie will not come in one line. Here is another example. If you have more imaging systems like OBSCAN or Pentacam, you can compare with the pachymetry map also and make a better diagnosis. I think Vinay would be dealing with that, so I'm not going into it. So this is a patient who has got an advanced keratoconus. Just look at K1, K2 will tell you that this is way abnormal. The K1 is 54.69, K2 is 48. Both are really out of normal area. And if you look at the whole area is red in color, so which is a lot of steepening in that particular area, well above 50 diopters. So that is keratoconus unless proved otherwise. You look at the fellow eye, there is a asymmetric bow tie pattern. The two bows of the tie are not symmetrical and they are not in one line also, which again tells you that it is keratoconus. This is a slightly subtle form of that. So this is what I was telling about asymmetric bow tie. So in the upper picture, you can see that in the picture shown with A, you have asymmetric bow tie, but both bows of the tie are in one line. But if you look at B, it is the one bow is at one angle, the other bow is at another angle. So there is an angle between these two. So that is called skewing of radial axis. So small amount of skewing up to 12 degrees and all, it's okay. But once it goes beyond 20 degrees, it's clearly abnormal. And keratoconus, because of the irregularity in the corneal shape, you will have an asymmetric bow tie, and not just an asymmetric bow tie, you will have skewing of radial axis also. So if you look at the this topography picture, you can see that K flat is 43.75, well within normal limits. The steep value is 47.97. It is high, but it's not way high. The cylindrical power that you see is about 4 diopters, which is again in favor of keratoconus. SRI is normal. Surface regularity index is perfectly normal. But if you look at the surface asymmetry between that is between two half of the cornea, there is a significant difference. So asymmetry is definitely there. The value is 1.18. So it's much more than 0.5. This is keratoconus. I think, yeah. So I think this is about keratoconus. I think Vinay will tell you about the tomographic dimensions of keratoconus also. Nowadays, we have got systems which can actually see the pachymetry in particular areas. And that if you compute, the diagnosis that you can make by looking at an image would be much better. So I will tell you a few examples which are pertinent for people who are doing regular cataract surgeries. So this is a patient who came for a premium IOL. The patient wanted glasses-free vision. So will you do a multifocal or not? So you look at the topography. You can see that in the central 2.5 millimeters of the cornea, there is so much variation in the power. So in one area, it is coming to about 37, the blue color, which denotes about 37 or 38. In one area, it is about 46. In another area, it is in the light green, which is telling you that it is 44. So the patient has, this patient is not a very good candidate for multifocal. If at all you do a multifocal implant, the patient will have suboptimal results. So you have to tell the patient properly. This is another patient who came for a multifocal IOL implantation. So you look at the topography, there is some asymmetry in the bow tie pattern, but you look at the superior and inferior areas. One is 42.7, other area is coming to about 43.4. The difference is not very much. It's about, I would say about 0.7 or so. So I think it is okay. We can consider definitely IOL, because the amount of cylinder is more. You have to go for a toric multifocal, if at all. This is another patient who has got a this is very symmetrical. It's like perfectly symmetrical, but there is high cylinder. So again, toric multifocal would be the option. So if you go for a multifocal, anything more than 0.75 diopters of astigmatism is not desirable. So then the multifocality, the IOL will not function optimally. Look at this patient. This patient again, like the first patient I was talking about, in the central 3 millimeters of the cornea, you can see multiple areas. One part it is 43, other part it is 42.3, other part it is 41.2. The results would be suboptimal if you do a multifocal IOL. Another example, this is a post-keratoplasty patient who wants to avoid glasses. So the patient had a high cylindrical power. The cylinder was coming to about 8.43. And he was highly unhappy with the about 5 diopter cylinder what we had prescribed. So the patient had developed cataract in the long term. So in such a patient, you can see that both of the tie are somewhat symmetrical. There is no much of a change in the central 3 millimeter. And the amount of cylinder that the patient has is very high. So you can go for a toric IOL. May not be a good candidate for a multifocal, but a toric IOL can definitely be considered in such a patient, and he can have a significant change in the quality of life after this. Another patient who was actually diagnosed to have keratoconus, when he came only for cataract surgery. The values, K values were 49 and 53. The patient wanted to remove the cylindrical power. He was wearing about 3 or 3.5 diopters of cylinder. So you can do, but again, you have to be very careful. So in the right side, maybe we can do, but you have to be sure, and you have to tell the patient very clearly that the results would be suboptimal, maybe better than just putting a cylindrical lens. I'll go to other things now in topography. One is the contact lens induced warpage. So this is a very common thing when RGP lenses were very frequently prescribed. Nowadays, we don't see. In contrast to keratoconus, you will see this localized steepening only in one central area. There is a sudden bump in K. It's exactly located inferiorly. In keratoconus, it will be located inferior. It can be located inferiorly, but it's more commonly seen infranasally or infratemporally. This is a patient who was wearing soft contact lens and he had an irregular pattern. This is related more likely to the dry eye. So you discontinue the contact lenses for a long period of time, about 3 weeks, and it comes to somewhat normalcy. Actually, this is a patient who came for laser refractive surgery. After LASIK, you can have descended ablations, which can give a lot of difficulty to the patients. Like in this patient, you see a lot of the centration is not maintained. The flatness of the cornea is to one side. If you see the central 2.5 millimeter, you can see that one area it is totally blue in color, which is corresponding to something like 35 or 37. And the other part, it is coming to near about early 40s, 43 or so. So such change in K values within the pupillary zone, that can give rise to ghosting and a lot of other photic phenomena. It is very useful in keratoplasty to assess the suture tightness. When you see sutures like this, so you remove the suture where the maximum steepening is seen. So in the upper picture, you see a cylindrical power of 9.7. So you remove the suture at about 5 o'clock position. And after that, you can see that there is a change in the the astigmatism. This is a patient who has a post-keratoplasty graft ectasia. So the upper part of the cornea, there is steepening, while lower part of the cornea, there is a gross flattening. If you see the flat axis, it is coming to 35.36. And if you look at the steep value, it is coming to 46.92. So it is way, way abnormal. So you have to do some corrective surgery to address this problem. You can also use topography for objective assessment of dry eye. I'll just take 1 or 2 minutes to tell you that I think a revolution has happened in the field of topography in the late 1990s with the discovery of OBSCAN, in which for the first time this tomography was added to topography. So we could really get elevation data. This happened in the late 1990s. And I think Vinay would be coming into details regarding this. Then came Pentacam imaging, which has become the sort of standard now. It came first in 2001. Now it has undergone several modifications. And it is, for refractive surgical practice, it is seen to be the standard. So there is another thing which came at 2007, in which the Scheimflug system, the Galilei system came in 2007, in which Pentacam, along with Placido, was incorporated to make it more sensitive. And the Galilei system is another Scheimflug system, which is very good, although it is slightly less represented in our state. There are multiple systems now, but I think the Placido, one advantage is that it's very sensitive. And if you couple it with OCT, OCT is very capable of measuring the corneal thickness accurately. So if you measure corneal thickness accurately, and if you have reliable surface data, anterior curvature, you can calculate the posterior curvature data. And this machine came up from Carl Zeiss, which is called Vicente Omni. And I think it came in 2009. And unfortunately, the company, because of its poor sustainability, because of most of the people who are buying OCT was for the posterior segment. And they didn't want to invest 20-25 lakhs only for the anterior segment imaging. So because it was not, the company was not able to sustain this particular model, they have discontinued it. But it's very good image. It gives very good image, a lot of information, and is comparable to Pentacam in a lot of ways. So in this, you get Placido disc-based elevation data. You have accurate data from OCT pachymetry, based on which you calculate the posterior curvature data. So the important thing is that the first anterior elevation data has to be accurate. So, and these can give images like this, something similar to Pentacam. And in addition, you can get OCT images of the anterior segment also. This is a patient who has got a Descemet's membrane detachment, well demonstrated in this. And the other advantage of OCT is that when the problem with OBSCAN or scanning slit technology is that it can be inaccurate in corneas which are way abnormal. For example, this is a patient who had a keratoconus, and in this OBSCAN measured the corneal thickness to be, thinnest point to be 329 microns. When the patient came to me, I just checked the ultrasonic pachymetry, it was coming to about 400 microns. We did the OCT imaging, it was coming to something similar, 410 microns. And so the patient who was denied C3R because of low pachymetry could be done. So as we advance in the imaging technology, I think we can give more and more help to patients. I think topography is a very valuable tool. It's indispensable for refractive surgery. And as people are moving into more and more advanced premium IOLs, I think it is becoming more and more important to cataract surgeons also. It's also very important in the diagnosis and follow-up for a lot of corneal disorders. Thank you so much.
Thank you, Dr. Anil, for that wonderful talk. Shall we move on to Dr. Vinay? Are you there?
Yes, sir.
Can you share your... Anil, can you remove your share? Yeah. Vinay?
Yes, sir. Coming.
Beyond topography. The line, Vinay, the line which appeared is due to your mouse. You hold the mouse and run. If you want remote, click your right button, it will disappear.
It's not coming in my screen at all. Is it coming?
No, it's not coming. Full screen. Okay, then it's okay. Fine. Good.
Any lines coming? Is my mouse visible?
Yes.
Thank you. So, Eid Mubarak to one and all. And thank you, KSOS, for asking me to do this. Now, Anil has given a very wonderful, foundation to what topography really stands for. And Scheimflug imaging is just one of the techniques of the many which is used to measure the cornea and the anterior segment. So we have actually moved from the question of topography to tomography, which is actually a section of the whole anterior segment. Now, when we assess the cornea, these are the three major factors which we do. One is the radius of the curvature, then the power, and the height. These are the three factors which we measure using any of these three different techniques. Clinically, it can be used for all these indications, but two major indications which we use commonly in clinical practice is for the refractive surgery and to detect corneal ectasia. So what is Scheimflug principle? Well, you can read through it. Actually, to tell you frankly, I really don't know what Scheimflug principle is. This is what it says, and it gives very little information to me. But basically, the difference is that as here in a normal imaging, all planes, that is the image, lens, and the film plane are parallel. But in Scheimflug image, it is tilted, and the idea is to give a better depth of focus. That is a principle or the idea behind the Scheimflug imaging. And this technique is used to capture the cornea and the anterior segment images in all these instruments. Of this, Pentacam is the commonest, and what we will be discussing about the pictures is what is called as Oculizer. It is the hardware is as Pentacam, but the software is slightly tuned to suit the refractive needs of the refractive needs, so that it can communicate or talk to the excimer laser. So basically, Pentacam and Oculizer are one and the same. So this is the kind of printout or picture that you see in any of the or most common of machines available. It doesn't matter, which machine is being used. Now, what are the things to look at? The first thing to do when you get the images to see what is the type of machine. Because if you know the type of machine, you will know the technique or the basic principle used to capture the images. Then look at the patient demographics so that you have the correct image with you and it's not a different patients. And then before you go on to analyzing or interpreting, see whether this print or the image capture is actually worth or is it good to analyze. So the quality, that is where the quality stands. Again, each machine has got its own criteria. In Pentacam or Oculizer, it is this one, what is called as KSOS. If it is colorless, it means the image is good. If the image is not good, see this picture, it gives red. Red means it's horribly out of the so-called normal range. And this is how it looks. And a few seconds after a blink, this is the image which smoothens out. So it is important to look at the quality of the image which before you start interpreting the maps. So again, let's go a little bit into the interpretation of the maps as Anil has said. So how do you interpret when you get an image like this? The first image which you usually look at is a curvature map. And what the curvature map stands for, everything has been described in detail by Anil. But in general, when you see the curvature map, the first thing you have to assess is how symmetrical or smooth this picture is above the horizontal meridian. Is it really smooth, or is it really a mirror image, or how shall I put it? Is it really comparable, the upper and the lower images about the 0, 180 degrees? Then the next thing to look at is the case. What the machine actually does, it is captures or calculates the flattest K and then gives the axis here. And what is 90 degree is what is given as the K2, the steep meridian. But what we have to understand is this is not the steepest meridian in the cornea. You can get another steep meridian, or you will find values which are more than the K2, which actually is the maximum K. So this is the first step in assessing the image. Is it smooth above or below the meridian? Look at the case. Is it in the normal range? And then Now, before I say that, what we have to understand is it's like something like a traffic signal lights. If it is green or yellow, it is probably in the normal range. Any hotter colors, it means yes, it is a sign for you to stop and relook at these areas. It may be abnormal. So once you look at the curvature map, the next is to look at the pachymetry map. So this is the pachymetry map. There are various different types of pachy values given. What is more important is the thinnest location or the thinnest pachy. What is the absolute value of the thinnest pachy, and what is the position? This is y is the vertical displacement, and these are two small things which has to be looked in Pentacam. If the y or the vertical displacement is more than 500 microns, probably it might indicate an abnormality. So in this one, pachymetry map is absolutely normal. The next is the elevation maps. What is elevation map? It's a little difficult to understand this concept. What elevation map it is, if I may simplify it, what the machine does, it calculates a sphere which actually corresponds to the curvature as much as possible, so that this sphere produces a maximum area of contact with the surface assessed. So in this map, this green area means that is where the best fit sphere actually is in contact with it, and that is normal. And the blue is below, and the yellow or the redder one is above the best fit sphere. And these are the usual normal pictures which you see. Now, how the abnormal pictures look, we'll come to a little later. Now, this is the next step. So, in this picture, if you compare the curvature, it is symmetrical above and below the horizontal. If you look at the pachy, good thickness, very smooth appearing picture, then elevation map is good to go. So it is normal. Like in the machines which Anil suggested, in Scheimflug imaging, especially in Pentacam, there are other factors which are there, or other printouts and other values which are there to help in arriving at helping us in diagnosing whether it is normal or not. In addition to this one, now this is an interesting fact, normal one, what is called as enantiomorphism. It basically means that the the curvature map of one cornea will be the mirror image of the other. If you see at the right and left, is actually mirror image of the one of the other. So this means it is a normal cornea. Now this is what is called as Bellin-Ambrosio enhanced ectasia, and this is one additional information which is given to help us in detecting more of the early or subclinical ectasias. What it does is, from the thinnest point, a 4 millimeter circle is removed from calculating the best fit sphere. So you get it more elevated than the from the normal best fit sphere. So you can pick up the subtle elevations early. And then these two are, variations of the thickness from the thinnest point to the periphery. And following these lines within these two is normal. And one other important factor is the D values. These are actually values which help us in knowing whether the various aspects like the front curvature, the back curvature, the pachy, the progression of pachy are within the normal range. If it is colorless, it means that it is within the 95% normal population. If it is yellow, it is 1 standard deviation outside the mean, and if it is red, it is 2 standard deviation. Actually, it doesn't mean it is abnormal, but it just means that it is outside the 1 or 2 standard deviation, and the possibility of the topo being abnormal is more. Now, this is the next case. Now, considering all these factors, let us try to read this topo again. So, when you take the curvature, is this symmetric above and below? I would say yes. Look at the case, reasonably okay. Then next is, how much is the thickness? Thinnest point is 538, which is good, which is a normal. And again, the elevation maps are practically normal. So we would consider this as normal. But to help, probably you can look at the Bellin-Ambrosio enhanced also, or BAT, what we call as BAT printout. Everything is normal here too. So this is practically a normal cornea. Now, what about this map? Same principle. Is the sagittal print symmetric above and below? Yes. Case normal range. Look at the thickness map. What is the thinnest point here? It is only 467. So, and again, look at the picture. There is a red, zone here. Red, as I mentioned, is always a sign of caution. Stop there. Look again, reassess for any abnormality here. So, cornea is quite thin there. So, what causes thinning? Always some kind of ectasia. Is it keratoconus? What are the other features to look for? Look at the elevation map. Here, the elevation map, the topo is normal, right? Like what what the pictures were shown, it is practically normal. Now, how do you define normal? One is the pattern here. Second is the absolute number. What these numbers indicate is how much each point is elevated or depressed below the best fit sphere. The actual number varies with machine to machine, but in Pentacam or Oculizer, for anterior elevation, any elevation above 13 to 14 is considered abnormal, or you have to take it with caution. And for the posterior elevation, any value above 18 is important, or probably may be abnormal. So, but then if you see, everything is within the so-called normal range. So, is this an abnormal cornea? Is this a keratoconus because of the thinning? Then you go to the bad display. Here again, everything is normal. Green, normal. There is no, elevation above or abnormal elevation. The PTI is also normal. The D values, except probably the thin, the DT, which is shown here is the thickness, slightly outside. It's about 1 standard deviation outside the mean, but then it's actually not really abnormal. And this is the other eye. Compare it with the other eye. It's a mirror image, again thinner, but everything is within the normal image. So this actually is a normal cornea, but thin. So consider this topography. Sagittal curvature, very red. The first look, we would say it is abnormal, very steep cornea. But then look at the symmetry of this picture. It is very symmetrical above and below the horizontal meridian. Quite steep. If you see the Kmax here, it is nearly 50 diopters. And if you actually see only the sagittal curvature, the possibility of us saying it as a keratoconus is very high. But look at the Pachy. Normal Pachy, no displacement, and again, elevations is normal. Bad display also is normal. So this is the right other eye, and left eye. This is actually a normal cornea, but steep. So this is a normal steep cornea. Is a refractive surgery possible in this? Yes, it is possible. You can safely go ahead with the refractive surgery in this case. And this is another example, another topography. Look at this. Again, if I say the principles, what I mentioned before, is it symmetrical above and below the horizontal meridian? No. If you can see here, there is a significant amount of steepening inferiorly. Now, how is the inferior? Why did I say it's significant? If you go back to the Placido-based system or the Rabinowitz criteria, which says that steepening of the inferior point by corresponding by more than 1.5 diopters is significant. If you see in the 5 millimeter zone here, it's 41.5 and it is 43.5. There is almost 2 diopter steepening. So there is a significant steepening inferior, and it is not symmetrical cornea. So that is the first red flag here. But look at the K values, normal. Even the Kmax is normal. What is the thickness? Normal thickness, not much of abnormality here. What is the elevation? Again, now this is another pattern of elevation. So if you see this one, this is a absolutely normal elevation. But if you see in this picture, what you see is what is called as an isolated island of elevation in elevation. Now, this is a significant factor. Isolated island is always to be considered as a probably abnormal. Now, isolated island alone is not enough, but isolated island with significant elevation. In this, it is hardly 5 microns. If it is 12 to 13 or more, probably it is abnormal. At the same time, sorry, if you see here, faintly, there is an area of very steep cornea, plus 0.17, sorry, plus 17, surrounded by 16, 5, 7, and 10. This is also an isolated island. Now, these isolated islands are signs that the cornea may not be absolutely normal. But then generally, it is less than 18 and less than 12, it is normal. It may be normal. And this is where you give more importance to the bad printout. If you see this is what we have seen in the previous picture. The posterior elevation is slightly, there is an isolated elevation. But when you take out this area from calculating the best fit sphere, then take the best fit sphere and calculate how much it is elevated. You see the elevation has significantly more here. From 15, it has gone up to 25. But the last one, what it shows is the difference between these values. That is in green, which means it is in the normal range. The difference is in normal range, but not abnormal. So though there is a significant posterior elevation here, it might not be abnormal. And D values are also reasonably normal. So is this a normal cornea? From whatever we have described, probably we will describe it as a normal cornea. But in topography, before we, or like in ophthalmology, for all things, before we say one eye normal, always compare it with the other eye. This is the left eye of that patient. See how different it is. Very steep, very asymmetric cornea, severe astigmatism around 8, thickness is only 487. Look at the elevation, very high elevation, 36, and posterior elevation especially very high, very localized, isolated island kind of picture, and a bad, very abnormal, lots of red, bizarre picture. So this actually is keratoconus in the left eye and right eye. Probably we can say as FFKC or even keratoconus suspect. Now, this is another picture. Very, symmetrical cornea, thick cornea. So is this normal? And this picture particularly shows the importance of having a true elevation map here. The anterior elevation is normal, but if you see the posterior elevation, there is a very well localized island with significant elevation. So is this abnormal? What about the enhanced ectasia? Again, there is a significant elevation posteriorly with red values. So probably yes, we may call it as keratoconus, which is subclinical. In fact, if you refract this patient, you will be able to refract fully and give him 6/6 with the glasses. But this might be subclinical. And what is important is these kind of cases are not suitable for refractive correction or LASIK. And at the same time, these kind of cases doesn't require any treatment for keratoconus in the form of C3I. They need continued follow-up to know any progression or change in the clinical scenario before you decide on treatment for the keratoconus. Now, this is another classic example of a very irregular cornea. If you see against the rule astigmatism, asymmetrical cornea, very steep, very high astigmatism, very steep cornea. What is seen as white here is areas which the image has not been captured or the machine couldn't capture image. But thickness is very, very thick cornea, 600 plus. Again, posterior elevations are quite abnormal. So what is this? This is a classic example of pellucid marginal regeneration. If you extend your imagination a little, you may actually see a kind of crab claw appearance, which is a classic, sagittal curvature described in pellucid marginal degeneration. Now consider this topo. Okay, again, classic crab claw. So what is this? Is this a pellucid marginal degeneration? Look at the rest of the pictures. So again, if you read like what mentioned before, quite asymmetric, high astigmatism, Pachy very high. Look at the thickness, very thin cornea, 443, but the thinnest point is actually at the center, and corresponding to the thinnest point is the maximum elevation anterior and posterior. So actually, this is a keratoconus and not a pellucid marginal degeneration, what may be described as PMD-like keratoconus. Now, look at this picture. Again, the symmetry, absolutely asymmetrical, corneas above and below the horizontal meridian. But if you take the central area, each point is bizarre, giving different, different values, 38 to 46 to 48. So this is what we call as irregular astigmatism. And for us, we see this most common in post-graft eyes, or if there is a corneal scar. This actually is a post-DALK patient for a keratoconus. So this is how the irregular cornea, astigmatism looks, and this is the same cornea 2 days after suture removal. So there is a change. If you can see, the amount of irregularity has reduced. To assess what change it has been, the suture removal has brought about, you can use what is called as the difference map, or compare the two exams. This one, the A is a post-suture removal, and this is the pre-suture removal, and this is the difference which the suture removal has brought about. There is a significant flattening which is brought about by suture removal, and as you can see here, the astigmatism after suture removal is just 0.6, while pre-suture removal is 3. So this is another, tool in the machine which can be used in various conditions. One is, as I mentioned here, post-suture removal. The next is in post-LASIK eyes to see where the ablation has happened. In this case, it is very central flattening, which shows that the ablation has happened as what we have planned for. This is another case after topographic pre-RK for CXL, post and pre, and what change it has brought. It has brought about the central flattening and slightly peripheral steepening. So, in addition to all these images, what the Scheimflug machines or the Pentacam has is the raw Scheimflug image, which gives you a cross-section of the anterior segment. The Scheimflug machine uses a blue visible light, and the reflected light is what is depicted here. This is a densitometry. So you can actually assess various factors in addition to the basic tomography of the cornea alone. Now, many of us who does C3R would have had a patient like this, who have had significant haze after C3R. Now, this is the Scheimflug image of the patient before C3R. If you can see, corresponding to this, the value of densitometry is just this, and 1 week post C3R, it has shot up to 100, persisting like that at 3 months. Then by 10 months, it starts to reduce, and in 2 years, it has almost normalized. So this is another tool which can be used with the machine. And again, same image can be used to assess the lens also. Here, the lens is very clear, and you can see what sort of reflectance it has produced. Consider this with the cataract, which has caused a significant amount of reflection from the lens. How useful it is clinically? Practically none much, but then it is good to show it to a patient to impress upon him that there is some, or significant change in the lens, and it needs to be operated upon. Now, this is a case of advanced keratoconus. You can see almost all signs of keratoconus in this picture: Fleischer's ring, Vogue's striae, scar, slit showing scar. Again, the Scheimflug image showing the scar with densitometry at various levels. In addition to that, a magnified image, you can see the scar and the very thin stroma and thick epithelium here. So a total of 400 is what was measured, but then when you analyze these corneas, you can see that the stroma is only 212, which practically rules out the possibility of C3R in these cases. A better option will be an anterior segment OCT, which would give a very clear image of these for this. I'm not sure whether this is clear. This is a post-ICL implant. You can measure the volt here, but then when you reverse the image contrast, you can see it very faintly. So these are some of the additional tools available in the machine. And one other important tool is the Holiday EKR report, which actually gives you the true K values at each zone of the cornea. And it is more important in post-refractive surgery cornea who is undergoing cataract surgery. You can take the 3 or 4 millimeter K directly for calculation of the IOL. So the errors of IOL calculation are much reduced. And then there are a lot of other options available, like corneal aberrations, Zernicke, Fourier, and all sorts of things which have been rarely used in the machine. Most commonly, what we use is the tomography, the quad map, which we have shown first for the ectasias and refractive surgery. Thank you.
Thank you, Vinay, for the excellent talk. Are there any questions from the audience? You can unmute yourself and ask questions. Vinay?
Yes, sir.
Excellent talk.
Thank you.
I'm just waiting for the questions to come. Yes, any questions? Sony is there. You want to ask some question on premium IOL and topography? You're welcome.
Yeah, Dr. Anil had said it will be a very useful tool in evaluating a patient going for a multifocal IOL. But is it very necessary to have this? Is it a prerequisite, or yeah, I understand that the posterior astigmatism can be missed and you can have problems, but generally, how important is it in analyzing a patient for a multifocal toric especially?
Assuming your cornea is a normal spherocylinder, that is okay. But if you have some abnormal corneas, I think definitely you cannot rely on your keratometry. That is not possible at all. But rarely, but that is pretty rare. Sometimes you see patients who have multiple, like cornea with multiple K values in the central 2.5 or 3 millimeter, which can really affect multifocal performance.
And ideally, it is better to go for a machine which has got a posterior float also, isn't it?
Yeah, that would be the best.
Yeah, because I have had an experience. I operated on a Nigerian lady with a simple toric IOL. The pre-op astigmatism was 2 and the post-op also was 2. I really do not know what happened, but probably I didn't do a posterior float, but I really don't know what went wrong, but because the IOL placement, everything was very much according to the measurements, and post-operative also I checked, but then I got a very, very erratic post-operative refraction. This patient I hadn't done.
Were in the normal range?
Which one?
K values were in the normal.
K values were in the normal range. Yeah. It was 45 and 47, and it was symmetric. And about this blinking, the dry eye influencing the keratometric measurements on topography. If you keep getting repeated, erratic values, would you suggest the patient to come back after
That is true. That is true.
That is
Quite
all.
often it happens when you do some something like applanation or your tone open measurement, and then it may not be very reliable. There will be some impression on the cornea. So it's better to do it another day after giving lubricants.
Okay.
And there is one question to Dr. Vinay. If you note keratoconus suspect change in a 25-year-old male patient who has come for something else like a LASIK, how would we proceed considering the age? When do we ask for the repeat scan to look for progression?
Right. Thank you, sir. So this is one of the most difficult, case scenarios in refractive surgery. The patient has come expecting to get rid of the glasses, and then you have to counsel and tell him, forget about refractive surgery. There is something else going on, okay, which needs a continued follow-up. Now, to coming back specifically to your question, how do you follow up these patients? My principle is I generally don't jump into keratoconus treatment directly, especially in the first visit, unless there are significant risk factors involved. In these cases, especially those who come for refractive surgery, who are not severely allergic or atopic, I generally call them back, or I'll explain the situation to them and call them back in 3 to 4 months' time for a repeat topography. And if there is a change or if there is an evidence of progression, then we'll consider for treatment. Treatment in the sense cross-linking, or probably topo-guided PRK with cross-linking to regularize the cornea a little.
I have a question for Dr. Vinay. You said if there's subclinical keratoconus, and you can give 6 glasses, most probably with the refraction. And would you, like, if the patient remains the same on repeated topographies, would you go ahead and do a refractive surgery? In that, you said CXR is not necessary. If continuously after three times you repeat in 6 months interval and the topographic pattern is the same, would you go ahead with LASIK or refractive surgery?
Refractive surgery, yes, but not laser vision correction.
Okay.
Okay, I would consider phakic IOLs.
Okay, ICLs.
There's one more question. Any topographic finding in KF ring? Dr. Anil, this is asked by Dr. Sabita.
KF ring. Huh?
Patient with KF ring, will there be any topographic changes?
I don't think so. I don't think. KF ring, what you meant is the copper deposition in the Descemet's membrane and the posterior.
Yes.
So in that, I don't think there is anything really in the literature to say that there is a specific topographic finding. At the same time, just because the patient has a KF ring, that does not give him immunity to keratoconus or in fact any other eye disease.
And, a lot of questions coming up. If we get dry spots in OP scan, can we put lubricant drops and do the scan the same day?
We can do that. But lubricant also can sort of has having an ironing effect on the cornea. But it's better than having a dry spot and interpreting it. There's no doubt about it.
What is the protocol that you follow for cross-linking in thin corneas? Hypoosmolar riboflavin, what is the time of application?
Vinay, you want to take that question?
Yeah. The thin corneas, basically as of now, the recommendation is anything less than 400, you shouldn't cross-link. Again, this 400, what is suggested is 400 microns without epithelium. Okay. Now, the hypoosmolar riboflavin is a big, I feel a big, big disappointment in the sense that we can use it to, swell the cornea, but then once you stop using it, within minutes or within the cornea goes back. So what is being practiced now by me is I don't use the routine riboflavin, which is the riboflavin with dextran. Okay, that is a hyperosmolar which causes further thinning of the cornea. Instead, what we use is riboflavin in 1% HPMC. The advantage of this is it is slightly hypoosmotic and it causes swelling of the cornea. Nearly 80 to 100 micron swelling of the cornea it creates. So that is what we use. And borderline Pachy 380, 370, what I do is I use a riboflavin, do a Pachy intra-op. If I get the Pachy as more than 400, go ahead with the crosslink. Otherwise, no. So the consent has to be like that if it is a very thin cornea.
Okay, then the next question is what?
Can I add a comment
Sure,
in
sure.
there?
Sony, go ahead.
Okay. I think I exactly follow what Dr. Vinay told. I think we have to be very cautious regarding cross-linking very thin corneas. And intra-op pachymetry is something very useful. But I think after removing the epithelium, a lot of people actually keep the eye open, which is not desirable. So as soon as you remove the epithelium, you put the riboflavin and keep the eye closed. It will prevent drying up of the cornea and thinning of the cornea to a good extent.
What exactly is topo-guided PRK? We are all doing topo and do the surgery now. What?
Well,
Okay.
Topo-guided PRK is it's initially in excimer machine, or when PRK or refractive surgery started, the treatment the ablation was just aimed at correcting the sphere and cylinder. Okay, the numbers were used to calculate the firing pattern. Now, as people understood that this alone is not bringing about the desired effect, just bringing the patient down to zero refractive error doesn't bring about the quality of vision. People looked into various aspects. Aberrometry came in, then the topography came in. Now, in topo-guided, the topographic pattern is fed into the excimer laser machine in addition to the refractive error. The machine calculates what is ideal for that particular cornea and then creates an ablation pattern taking into consideration the existing shape of the cornea in addition to the refractive error. And this is topo-guided PRK. PRK is a surface ablation. LASIK is you create a flap and do it. Topo-guided can be either PRK or LASIK. In keratoconus, you don't do a LASIK. So you do a topo-guided PRK to smoothen out the surface irregularity a little. As the picture I have shown, what it has done is it has actually shaved off a little stroma from the apex of the cone, and at the periphery it has steepened the cornea. So you get a much more smoother cornea at the center. This improves the uncorrected and best spectacle corrected vision after procedure.
We'll move on to the next question. Regular ophthalmologists not having these equipments have inter and optical biometer planning JG. What is JG? I don't know. For multiple focal, trifocal, how to plan? I think you can read that question.
I'm not sure what it means. I mean, all of us were using the regular biometers and optical biometers for multifocals, trifocals, toric. The recommendation is that you should have a topo to know how good the cornea is. Rarely, yes, you can land up in problems if the topo is not done. It's not a very common outcome.
And the next question is significance of KISA index in diagnosis and following of keratoconus by Dr. Malliga. significance of KSA index?
KSA index was very important, was considered important about 15 to 20 years ago, before the tomography came. But now that the tomography machines are very well accepted, now its significance is not much. I think for a person who only has a topography machine, that's okay. You can for a diagnosis or for follow-up, it may be useful, but I think tomography has to be added on to it, and you should look at the cornea in the whole perspective rather than looking from the surface alone.
So, ideal candidate for CR3, and what are the poor prognosis situation, Dr. Jayalakshmi?
Well, hopefully, we all, want no candidate for C3R. Okay, but yes, there is nothing called ideal. C3R is basically, I do only if there is a, demonstrated progression in keratoconus. If there is a progressive keratoconus, then yes, C3R has to be done.
Then what is the cost of C3R?
Difficult to say. The machine varies from 8 lakhs to what is the Indian made to 25 lakhs, which is imported.
Then 32-year patient diagnosed as keratoconus, will you advise C3R, Dr. Mallika?
32-year-old male patient, first visit, I will not. But 32-year-old female patient, first visit, who is planning for a pregnancy in the next few years, I will not hesitate to advise cross-linking. Same if the patient, whether a male or female who has severe atopy or allergy, advise the threshold or the hesitancy in advising C3R is very low. All other cases at this age, I usually wait, reassess 3 to 6 monthly interval to see if there is any progression. In case of progression, yes, cross-linking.
What is the normal KRI bar KAI? Can you read that, Vinay?
Sorry, I didn't get what it meant.
What is the normal KRI bar KAI?
Okay, is it SRI and SAI? If it is SRI, normal values up to 2 can be considered normal. More than 2 would be abnormal. If it is surface asymmetry index, up to 0.5 is normal. Anything more than 0.5 would be considered abnormal.
It must be SRI. And is post LASIK ectasia, do we look for progression or do cross-linking directly?
We don't wait in post-LASIK ectasia. Diagnose post-LASIK ectasia as early as possible. We do a cross-linking.
Patient first visit having Pachy 380, can we do cross-linking? You've already answered that.
Yes. There was a question above that, sir, which we missed. Can we decide which suture should be removed after corneal grafting from topo? The answer is yes. Generally, we do a topo and assess which meridian is steeper, and you remove the suture in steep meridian. That is early after keratoplasty.
Then there's one more question, but by Edwin, I think I missed it. Can you calculate the angle kappa in Pentacam?
A certain angle alpha. No, unfortunately, angle kappa and angle alpha is not. I mean, you cannot directly get from Pentacam, but you can take it as half the distance from the center of the pupil to the apex. It gives a value at the center of the pupil and at the apex of the cornea. and how far the center of the pupil is from the apex is also given. So arbitrarily, you can take half this distance as angle alpha. Angle kappa.
Are there any questions directed directly to you? Because I didn't have that question in the everyone section. It must have been sent to you. Just look at your chat box and answer if there are any questions. Anil, just check your chat box.
I am doing that, sir.
Because if they are not sending it to everyone, we will not know. Sir, for suture removal post PKP, how many months post-op do we do the topo?
How many months post-op? See, it depends upon individual case to case. It depends upon how the vision is after the surgery and what is the manifest refraction the patient is getting. If there is good vision with acceptable cylinder, then you can there is no actual indication for doing a topography post PKP. How soon? As early as the patient wants, or as early as you are planning for a visual rehabilitation for the patient. 1 month, 3 months.
I think there is one more question. Can we get SRI and SAI in serious topo?
In serious, I don't think it is there with the printouts what I have seen, but I have not really gone into the software and looked into whether it's possible or not.
What has to be understood is you have to really learn each machine you have access to. Each machine is unique in terms of the software and the statistical indices it gives. Serious has got an entirely different set of indices. Pentacam has different one. The TMS is different one. The Atlas, which is from the size, has got a very different set of statistical indices. And whichever machine you have access to, we have to learn those things.
There are no more questions, and I find Dr. Meenakshi Dhar madam has joined us. Welcome, madam. Do you want to ask any question? Yes.
I've been listening. Yeah, a very good talk. Both the talks are very nice, and it's great that each of these parameters is always confusing to people who don't use these maps. A very well taken class by both Dr. Vinay and Dr. Anil. Thanks.
Thank you, ma'am.
Thank you.
Mahesh, are you there?
Yeah, I am here.
Can you give the concluding remarks?
Actually, I am totally unconnected to cornea, but I see the response to the talk and review and question answer session. I felt it is very useful for everyone, not only postgraduates, those who are practicing. I thank Dr. Vinay and Dr. Anil for this nice session. And congrats, Raju. You are doing wonderfully well. For that.
Thank you, Mahesh.
Thank you.
Okay. Thank you so much. Thank you, Anil. Thank you, Vinay, for that wonderful talk. It will remain forever in the YouTube.
I think it was a wonderful talk by both of them, from the rock bottom basics to the very useful information for a general ophthalmologist as well as a cataract surgeon. And congratulations, Dr. Rajiv, also for conducting these wonderful sessions.
Welcome. Thank you so much. We'll conclude with this. We'll see again tomorrow, next week, same time, 11 o'clock, with a new topic. Thank you so much.
Thank you, sir.